Well, welcome everybody. I'm so glad that you could be with us today for our webinar on protecting medically complex, medically complex and or immune suppressed children with DEEs from COVID-19. We have assembled a really fantastic panel and we're so excited about today. My name is Gabi Conacher. I'm the president and co-founder of Wishes for Elliot, a small family-led nonprofit that is focused on supporting families with DEEs. And DEE-P Connections is a project that we started just a couple months ago, really, to help provide this kind of support to you and your families so that you can live healthier lives and get your questions answered by fantastic experts like we have with us today. I'd love to thank a few people before we get started. And Patty Schaefer from Epilepsy Foundation, who was a critical resource to helping us pull this together. Heidi Grabenstatter from International Foundation for CDKL5 Research, who is going to be your host today. And then, of course, all of our panelists who you'll get to know in just a minute and hear from, and they'll answer as many questions as they possibly can in the time allotted. Thank you all for joining us. We know life is very scary right now. We live a life of protecting our children at all times, and this is just a heightened level. So we're thrilled that we have this panel here to help answer your questions. And just quick housekeeping that today's session is being recorded and will be available online within 24 hours. And if you have any questions, please add them to the Q&A in the taskbar. All right, Heidi, I hand it over to you.
All right. I have my slide here. I'd like to introduce our panelists here. We have Dr. Henry Fraimow from Cooper Rowan School of Medicine. He is an infectious disease specialist, and he'll be here to answer your questions about the virus itself and how we can manage the virus in our homes and any specifics about it. We've had several questions about the nature of it. Is it enveloped? Does it travel on packages that we're receiving? We also have Dr. Elaine Wirrell, who is the Director of Pediatric Epilepsy and Adolescent Neurology Residency Training Program at the Mayo Clinic. She is the co-founder of the Pediatric Epilepsy Research Consortium. And we also have Dr. Anastassios Koumbourliss, who is a pediatric pulmonologist. So collectively, these specialists, I think, will do a fantastic job of answering all the questions we have as a population of DEEs regarding our children and as caregivers. I'm really excited they were able to make time given all of the work that they have with this virus and what they're doing in the hospitals with their day jobs. So this is fantastic. In the evening, they're able to make time for us. I will be keeping track of the Q&A questions, and we'll be dishing them out after Dr. Wirrell gives her talk here. So I think we could start with the slide presentation.
All right, I'm just going to sign on and make sure this works. So what we are, there we are. Can everybody see that okay? Perfect. So what we wanted to do is to just do a very brief overview of COVID-19 and what we know about COVID-19 in children, and specifically children with the DEEs and children with neurological disability. And then we're hoping following that we'll be able to get to everyone's questions. So what do we know about COVID-19 in children, and what data do we have from the countries where COVID-19 has already been more prevalent than in the US? Are those with DEEs at actually higher risk of contracting or getting COVID-19 infection? We'll then look at what if you get COVID-19, are you in fact at higher risk of severe disease with COVID-19? And then what can we do to try and keep our kids as safe as possible? And what precautions should we consider as we're going into this pandemic? So what do we know about COVID-19? Well, we know that symptoms typically begin about 2 to 14 days after exposure. And most patients will start with a cold-like symptom. So they'll have fever, cough, not terribly short of breath, but that can be a concern. And some children will also get vomiting and diarrhea, but that is probably less common than cold-like symptoms. So it looks like sort of a pretty generic viral infection. Overall, we know that children do have less severe disease than adults. And there's some preliminary reports from colleagues both in China as well as Italy that suggest that there is actually low risk of worsening seizures in children with epilepsy. So that is preliminary good news, but these are just reports from talking to some of my colleagues. There's no big studies that have looked at that yet. This was one study that came out a few days ago, and it looked at over 2,100 children who had COVID-19. It came out of China, and they looked at the severity of disease in children. And what they found was that just over half of them, 55%, were completely asymptomatic or had just very, very mild disease. They had about 39% who had moderate disease, and these were children who typically had pneumonia, but who did not require hospitalization. And then they had about 6% of children who had more severe disease. So 5.2% was severe, and 0.6% of kids were actually critically ill. And of the number that they looked at, they in fact had one death in 2,100 children. When they looked at what were the factors that led to more severe disease, what they found was the age was important. So the younger the child, the higher the risk. And if you looked at infants, so children under the age of 1 year, of all of those infants who had COVID-19, 11% developed either severe or critical disease. So that seems to be a higher risk group. When they looked at children between the ages of 1 and 5, that number came down to 7.3%, so still potentially of concern. And it was much lower in teenagers, so only 3% of teenagers actually developed severe or critical disease. What the Chinese study did not look at, though, was underlying conditions. And other studies that have looked at other types of coronavirus, but non-COVID coronavirus infections, have shown that kids that are younger age, those with some type of underlying lung disease, or patients who have a compromised immune system and maybe can't fight off infection as well, do have more severe disease with the non-COVID-19 coronavirus infections. So that might suggest that, that children who have similar conditions, younger age, underlying lung problems or immunocompromised states can also become more ill with the COVID-19. So one of the questions that we often get is, are children who have epilepsy, and particularly the more severe epilepsies, at higher risk of contracting COVID-19? And we know that COVID-19 is actually a fairly infectious, highly infectious virus. And the risk of contracting it, the risk of getting it, really depends on exposure to an infected person. So probably that risk is pretty similar. Are you going to get it? Are you actually going to contract it or not, depending on, or sort of regardless of whether you have epilepsy or what type of epilepsy you have. But we do know that those who have the developmental and epileptic encephalopathies, those patients can actually be at higher risk because maybe they're exposed to more caregivers to help with their activities of daily living. And we know that a higher risk of exposure to multiple people does increase your risk. And also, if your caregivers are ill, they're actually touching their face, they're touching your face, they're doing a lot of mixing of medications. And so there's a lot more contact. So that may be one reason that they are at higher risk. And we also know that children who have the DEEs are children who often go more frequently to the doctor. So they have more frequent medical appointments. They often end up in the ER more frequently, more hospitalization. So again, increasing the number of patients and the exposure, so they may be at higher risk of actually getting COVID-19. So the next question is, if they get it, are they at higher risk of having a more severe infection? And when we look at severe infection, that's usually pneumonia. And pneumonia can progress to cause problems with shortness of breath and decreased oxygen in the bloodstream, so that can certainly be a concern. You can also get overwhelming infection, And we know that if you have a viral infection, that could put you at risk of other types of infection as well. So you could have what we call superinfection or another infection that happens. Some of the patients have developed heart failure or other failure of their kidneys or their liver or things like that if they get very sick. And we know that children who have underlying medical conditions or special needs, in fact, can be higher risk of severe disease, but the data is pretty limited there. This is not something that's been well studied with COVID-19. So what do we know about COVID-19? And that is that persons with other chronic medical issues, particularly heart problems or lung problems, or problems with their immune system, are at higher risk. They can't fight the infection as well. And so why might children who have the DEEs be at higher risk of pneumonia? We know that many of our children have difficulties with aspiration. So that's when they're actually swallowing and the swallowing mechanism doesn't work well. It's discoordinated, and a lot of what they swallow can go down into their lungs. And we know that that's a bigger risk if you have a child who's having frequent seizures, swallowing dysfunction, if there's difficulty handling secretion, so oftentimes these kids drool a fair bit, they have a poor cough, they have a difficult time actually getting those secretions out. And then some children who have limited mobility, if they can't really roll over and move around, those secretions are more likely to pool. And then many of our children also are on lots of medications, right, to try and reduce seizures. And while those medications can be helpful to reduce seizures, many of them also cause problems with sedation. In addition, some of the children with the developmental and epileptic encephalopathies are treated with specific types of therapies that also can have a negative impact on the immune system. So I think what's important to know is that most of the seizure medicines that we use are not impacting on the immune system and should not put the child at increased risk. But there are some that can. And the ones that are most concerning are ACTH, and that's often something that we use for infantile spasms. I suspect that many of your children may have been treated with ACTH at some point. Prednisone, which is a steroid medication, which can also suppress the immune system. And then everolimus, which is a particular medication that we use for children with tuberous sclerosis complex, that also can suppress the immune system and put one at greater risk of pneumonia. We also know that children with DEEs can have specific underlying conditions that can actually lead to those DEEs. And some of those conditions are what we call metabolic disorders or neurometabolic disorders. And anytime the body is then exposed to some type of intercurrent infection, that's a stress, and that can actually worsen the underlying metabolic disorders. And so that would be, as an example, a child who had an underlying mitochondrial disorder. So what can we do to keep your child safe? And I think the biggest thing you want to do is reduce as much as you can. And we know that you can't put your child in a bubble and prevent anything from coming through your front door, but we really want to do as best a job as we can of reducing exposure. And frequent hand washing is really, really important. And it's not just doing it, but it's doing it right. So you have to sit there and count 20 to 30 seconds washing your hands. You want to, as much as possible, avoid touching your child's eyes, your child's mouth, your child's nose. And if you have caregivers coming into the home and you're concerned there, I think using gloves makes sense. You want to be very careful about cleaning or disinfecting frequently touched objects or surfaces. If you're mixing your child's medication, you want to make sure that that surface is actually clean. Obviously, avoiding larger gatherings. The less people you can be exposed to, the lower your risk is going to be. Many people are now working from home. And then avoiding close contact with people who are sick. So I think that there should be a rule. Anybody who is sick is not welcome to come to your house right now. Anybody who's had possible exposure to COVID-19 or influenza, you probably don't want them through your front door. One of the concerns then is, what if a sibling or a parent gets sick? Because it's easy to say to your caregiver, geez, stay away. I don't want you to come until you're better. But what happens if one of your family members gets sick? And that's more challenging. So again, you want to minimize exposure as best you can. Ideally, if it's a child, can they go stay with someone else for a while? But usually that's not possible. And so what you want to do there is really isolate as best you can. So each person should have their own room. They should have separate bathrooms, and you're really wanting to make sure you wash hands frequently. So what can you best, or how can you best prepare for potential COVID infection and try and keep your child as healthy as possible? And I think there's a lot of chaos happening in our world now with COVID. A lot of things are not working as they normally do. A lot of schedules have been very much changed. And I think what's really important is to try and stick to that medication schedule. And if you need to set alarms on your phone, or you need to do something to help you remember that medication is due now, that's something that we need to do. A lot of concerns have come up about adequate supplies of medication. And as far as we know right now, there is no evidence that we are short in any particular seizure medication, and that is being really carefully monitored by the Epilepsy Foundation. What is recommended is that you probably keep a supply, a 30-day supply or greater of medication available. And that can be challenging sometimes with insurance, right? Because sometimes insurance doesn't let you fill that prescription until you're kind of down to your last couple of pills. Now there actually have been several plans, including some government plans and some private plans, that are allowing more flexibility with COVID-19. And so some of those plans are actually removing prior authorization requirements. Some of them are waiving prescription refill limits or letting you get prescriptions for a longer period of time, and then allowing home and mail delivery of prescription medicines that often allows you to get a larger supply at any one time. So I think very helpful, if this has been an issue in the past, maybe talking to your pharmacist, talking to your insurance, and see if things have changed, because with some of the insurances, things have changed recently with COVID-19. So talk to your pharmacist, talk to your healthcare provider. And remember, this also includes over-the-counter medications, so things like Tylenol that you might be needing, or other supplies, nutritional formulas. The other thing that you can do is to make sure that your child's rescue plan is updated. I think most of the patients who have DEE do have some type of rescue plan that's been given to you by your neurologist. You want to make sure that that is updated and current. So if your child has gained a lot of weight, is the dose still the right dose? Do you have adequate rescue medication actually in the house to give? If your child's seizures are worsening, this is, I think, where you want to be a bit more proactive, and you want to be calling your provider earlier than you may have and say, look, things are getting a little bit worse. Because ideally, you'd like to be able to make some of those medication changes. You don't want to be in a seizure emergency and having to take your child into an urgent care center or to an emergency room. You want to try and be proactive about that. And hopefully, if you make some medication changes, you can settle those seizures down before they get worse. If your child has routine medical visits, and we know that many of your children see their neurologist, they see a pulmonologist, they see a general pediatrician, they may see, physiotherapists. So many of them are going through multiple different medical visits. And many centers in the US now have switched over to do video visits or phone visits instead of inpatient visits. And so if your child is just going to be seen for a routine visit, there's nothing really acute that's going on, what I would do is call your provider and say, look, can we do a video visit or a home visit instead? Or is it possible to safely postpone that visit? The other thing that I think is really important for people to do is, this is a very chaotic time. This is a very stressful time for yourselves as caregivers, for everyone in your family. And just take time to also pay attention to wellness. Make sure that your child is getting adequate sleep, your other kids are getting adequate sleep, and make sure you are getting adequate sleep, because you don't function very well if you're really sleep deprived. Pay attention to nutrition and put in place some fun activities for your child, for your other children, so that people are not sort of worrying about always having this crazy COVID to worry about. So we all really need to look after each other here. So then what if your child actually develops symptoms? So if you or your child or another family member does develop potential symptoms of COVID, you want to call your healthcare provider to discuss and arrange possible testing. We don't want you actually going to the office, because again, you could expose other people at the office, or if you don't have COVID, there could be somebody else at the office who does, and they could be exposing you. So unless there's an emergency that arises, you really want to avoid going to medical offices, going to urgent care clinics, going to emergency rooms. To manage seizures during illness, so we know that many children, if they get ill, their seizures increase, and that's probably for a number of different reasons. So the seizures themselves can cause stress to the body. Oftentimes, illnesses cause fever, and that can also lower the threshold for seizures. Many children, while they're sick, particularly if they're coughing or there's problems with their breathing, they don't sleep as well, so then they're sleep deprived. And some kids also can have some vomiting and diarrhea, and that can interfere with them being able to take their medication and keep their medication down. So how do you actually try and manage this during an illness? So again, making sure your child takes medications as prescribed. If they're unable to keep those down, you want to talk to your doctor. You want to talk to your doctor about treating other symptoms of the virus to really help your child sleep as best as they can and help them feed as well as they can. And then if seizures worsen, follow the rescue plan that you have and let your doctor know that the seizures are worsening. So the question is when to seek emergency help, and realize that emergency help is there and should be used if you absolutely need it. So a seizure emergency is if your child is having prolonged or clusters of seizures that are not responding to the seizure rescue plan and those seizures are not stopping. That would be something that you'd need to call EMS for. If your child has had some respiratory symptoms and now seems to be getting more short of breath, developing a bluish discoloration, or seems to be really working very, very hard to breathe, that could be a sign that they have a pneumonia that is getting worse, and that would be something that they would need to be seen urgently for as well. And then if they're having difficulty eating or vomiting, if there's concern for dehydration, they can't keep their fluids down, they've had severe vomiting or severe diarrhea, and then you're looking for signs of dehydration. If their eyes look really sunken, their wet diapers are much decreased, their mouth looks very, very dry with little saliva, that would be something also that they may need emergency care for. So where to get more information? Epilepsy.com has a section on COVID-19 and seizures, and that is being constantly updated. We did a Facebook Live just on general epilepsy and COVID-19, so that's available on that site. The CDC, I think, is a very good site. Your pediatrician or your primary care provider, they know your child best, and so they are wonderful resources, I think, in this setting, and can give you really good advice. They know what the situation is in your community, what the situation is at the closest hospital, and then your neurologist or your epileptologist. So I think we are happy to take any questions that anybody has. Heidi, I think can you unmute yourself?
There I am.
Okay.
I have a whole list. I've been collating them as they come in. So many of them overlap, and you've covered them, Dr. Wirrell. So we'll hit them one by one. One that's been asked several times is, should we be canceling home nursing and in-home therapy services to protect our children and minimize exposure?
So I think it's really tough. You cannot do anything to guarantee that coronavirus is not going to come through your front door. But I think what you can do is, as I had said, try and minimize that exposure. Now, I think recognizing that the reason that a lot of people are coming in for care for your child is many times that's actually really needed. It's not something that families are able to do completely 100% on their own, and so there's ongoing care, maybe physiotherapy, things like that, that could actually, help with particularly chest physiotherapy may reduce the risk of infection. So I think it's a bit of a balancing act. What you want to do is you really want to make sure nobody comes into the house who's sick or who has been in contact with somebody who's been sick. And you really want to minimize the number of people you can come through. So rather than have sort of one nurse that comes in one day and a second nurse the next day and a third nurse the next day, if you can try and limit that to, it's going to be the same person coming in every day, I think you're going to be exposing your child to less people and reducing that risk.
With that, I'll just move to the next question. I don't know whether we have some people raising their hand, so I don't know if we want to continue with discussion as we answer questions or if we want to move on and try to cover as many topics as possible.
Do my colleagues have any comments about sort of the additional help coming into the home? Any other advice?
Yeah, hi, this is Henry Fraimow. I'm not sure you can see me. I don't know where my video went, but so yeah, this is a big challenge because we don't know what our caregivers are doing, and we know that in many of our communities, there is a high rate of a COVID disease spreading through the community. So I agree that minimizing the number of diverse healthcare providers and also having an open discussion with your usual healthcare providers to make sure that they understand that if they're sick or feeling any symptoms, that they shouldn't be coming in. And, you know, and that can be sometimes challenging because this is their livelihood, and they may not want to necessarily tell you if they're not feeling well. So the more open you are with them, I think insisting that they wash their hands when they come in the house and continue to use hand hygiene throughout the process of care. I don't think I can give you any recommendations that all, you know, providers who are coming into the home should be forced to wear a mask, but I think that that is certainly, you know, we know that, you know, a typical surgical mask is very good at preventing transmission from somebody who might be infected. So that's something to consider, but I don't think that I can tell you that that's a definite recommendation. But certainly if it's lots of providers and people that you don't know and have an ongoing relationship with, it's something to consider.
Dr. Koumbourliss, you're on mute.
Sorry about
there
that.
you go.
Okay, can you hear me now?
Yes, we can.
Okay. I agree with my colleagues, and we need to be a little realistic about all of these things, in the sense that there are things that we would like to do and things that we can do. The question is, can you afford to be without any nurse, for example? And, you know, the condition of the child sometimes makes it possible, at least for a short period of time. Some other times it's impossible. I mean, there are a lot of parents who run whole intensive care units in their houses. They do need to have the help. And I think that practical things, you know, like the mask, yes, minimizes the risk. It does not eliminate the risk, and minimizing the number of people minimizes the risk, but does not eliminate the risk. These are practical solutions that clearly differ from place to place, from, you know, home care company to home care company, how many nurses are still available. Yes, if you have the choice, you prefer the same person, you prefer a person who does not work half of the day in an emergency room and then comes to your house. But again, we cannot really have a blanket statement applicable to everybody.
Thank you. I think moving forward, we have to be careful as we answer these questions. A lot of them are very specific. The doctors have to be careful about giving specific medical advice. It's a slippery slope. So we'll have to be speak in generalities to a certain extent. So be patient with us. The next question is regarding the virus. Does it live on inanimate objects? Does sunlight kill it? Is it enveloped? Many of the caregivers receive a lot of supplies in the mail, both medications, diapers, and other supplies for their children?
So I'm happy to start answering that one. It is an enveloped virus, just like flu is an enveloped virus. The good thing about enveloped viruses is that they are readily killed with soap and water and with alcohol. They can live on inanimate surfaces for generally periods of up to several hours. I mean, you'll see reports that they can last for longer periods, but from a practical perspective, I don't think you have to worry about them, hanging around for weeks on inanimate surfaces. The risk is not really the packages themselves, but really the hands of the person who's delivering the package and dropping it off, which is really the risk. It's not that the package itself carries something from far away, but it's whoever's handling that package in the process of leaving it at your doorstep. And I think that I would treat a package at the doorstep the same way I would treat a visitor, right? You're going to wash your hands before you touch them. I think if you're rigorous about hand washing before and after you touch the package and open it, the stuff inside the package, especially if it's been in there for more than a couple of hours, should be fine. It's really the outside of the package that provides any of that potential risk. I don't know if any other panelists have thoughts as well.
Yes, I totally agree with you. Correct me if I'm wrong, but the way that I'm trying to see at these things is from a practical standpoint. If your child has never gotten an infection with the flu or any other virus from a package you received in the mail, there is probably low probability that they are going to get it, from the mail that you get these days. Now, low probability, of course, does not mean impossible. There is always the possibility, and I agree that using the usual procedures to clean your hands before and after minimizes significantly the risk.
I would agree. I don't have anything further to add.
All right, then we'll move on. I'm going to skip the question about nursing because we've covered it. There's a question about having someone come to the home to draw labs. And I think I will extend that. People are hesitant about taking their children to the doctor's office. And also, I think we could extend that to clinical trials. A number of our communities have active clinical trials that require blood draws. And how those there's been a recent release from the FDA about how those should be handled by industry, but any guidance that you might have for our communities about blood draws and how clinical trials might be handled and labs.
So I would say for blood draws, really the question is how urgently are those needed? So I think the first question is talk to whoever has ordered those. Is this something that really needs to be done now, or is this something that can wait, 6 weeks or 8 weeks when things I think hopefully will be more safer? And so I think there's oftentimes we'll do routine blood levels of medication. And I guess the question is how much is that really needed? Is that going to change what we do? Obviously, if you have a child where the seizures are really getting out of control and you're already on a pretty high dose of medicine, then it may be needed. Your doctor may need to know what the level is and is there room to move up on that. But I think for routine labs, this is not the time that I would be signing up my child to go get routine labs. For the clinical trials, many of the companies, in fact, the FDA has said that we can do those visits remotely. We can do these as video visits or phone visits. Some of the kids are needing specific types of testing done, echocardiograms, things like that. And for now, those can probably be put off at least 4 to 6 weeks is the directive that we're getting. For the labs, they like to do the labs, but again, that's something I think I would talk to the neurologist, because we really want to balance that. We don't want to send your child off to get, just a blood count and liver function if the high likelihood is that those are going to be normal, but there's also a significant risk to your child that they can actually get infected if they show up in a lab. I think for the investigators, what they've told us is we just need to document that we've done due diligence. So we need to document that we've talked to you, that we've assessed whether there are side effects, and then we need to document why we couldn't get those labs, why we thought that that was not a good idea, balancing the risk and the benefit. I don't know if my other colleagues have anything to add to that.
Experience, and actually a lot of the sponsors have already said that first we use the clinical judgment, and because this is something that is affecting every center in the country, everybody's having the same problem. So the data, yes, are going to have some gaps, and in the analysis of the data in the end, they will have to take this into account, that the specimen was not drawn exactly in 2 weeks or whatever weeks it was supposed to be. So I think that pretty much everybody is on board, both the investigators and the industry, on these issues.
And I think the other thing to say is that the companies, at least the ones that we have been involved with clinical trials, have also made a commitment that the children are going to continue to get those medications.
Fantastic. Does anyone else have anything to add?
Nope, I think that covers it. I mean, I think the concept is the same about any non-urgent but routine medical procedures and visits. It's really, if it's just routine, then the risk probably outweighs the benefit.
I think we'll run into risk-benefit questions again and again as we run through these. The next question is about medications, but in particular about insurance roadblocks regarding both, but in this case, a G-tube keto formula. This particular patient has multiple medications and has run into issues getting the backstock that has been recommended with by the CDC, and if there's any guidance on how to get any more than the 1 month, or if 1 month is all we're recommending at this point.
So what is being recommended right now is 1 month. But again, I think you want to have a full month's supply because it can take a while to get that resupplied. What I would do in that situation is I would actually talk to your pharmacist to begin with, and just make sure that the rules haven't changed, because as I had mentioned, with COVID-19, many of the insurance companies are actually relaxing a few of their rules. And that differs, unfortunately, from one insurance company to another, and I know it can be a very big frustration, but to make sure that that hasn't changed, or call your insurance and see if that hasn't changed. If you're still really looking at, you're running very short on medication, it looks like you're going to run out, you're really having quite a challenge, the Epilepsy Foundation can also help you out too, so that would be something to reach out to, but they typically would step in when it looks like you're really going to be imminently running out of your medication.
We're running into more questions, I think, here, unless anyone else has more guidance on meds as far as the experts. Okay.
I'm covered.
All right. We have people are asking about just the parents needing a break from time to time for their mental well-being, and how options for them to get help during this time when you're avoiding having extra people in their house. And we've already talked about nursing care.
So I think well-being is really important. We don't know how long this is going to last, and we know that we have to get through this. And what that means is that we need to focus very much on our child, and you do that every day, every minute of every day. But I think the other really important part of that is well-being for your other children and well-being for yourself and your spouse. And so getting a break is really, really important. You need to get out and recharge your batteries from time to time. Otherwise, your ability to continue to do this day in, day out is going to be very, very challenging. So what I would then think about is how can your child be looked after as safely as possible, and whether that be bringing in somebody from your nursing agency, whether that be, you know, contacting your brother or your sister or a family member who potentially could come in and look after your child. Those would be things to have a discussion perhaps with the family members, perhaps with your social worker, what was available to you. But I think it's really, really important. Everybody needs their batteries recharged, and you have to look after yourself too.
The only thing I would add to that is that many of us are already living in communities that are essentially in lockdown, where there are severe restrictions to even the ability to go out. And I think that's creating that same issues with social isolation for everybody who's being impacted by this. And so I think we all need to, ourselves and our families, have to develop online alternatives to those interactions to make sure that you are that you're participants in support groups, participants in Facebook groups, and have outlets outside of the home. Because if you're going to be stuck in the house and only allowed to go to the drugstore and the grocery store for the next month, it's important to make sure that you have those outlets to enable life to continue.
If I may add, again, from a practical standpoint, if you need a break and there is somebody who could provide this break, make it easy for them and for you. For example, most chronic patients have a schedule to give medications 2, 3, 4 times a day. Ask, if possible, the person who's coming to come in between these times so they don't have to deal with the 10 medications and you know that you need to give. It minimizes the exposure, the actual exposure of the child, you know, to the person who comes, you know, just to be there in case that something happens. And also for the people who, if they are able to walk and come to your house, it is good to emphasize that actually your child in this case, although he or she is the patient, but at the same time is the safe patient. They are not going to take care of somebody who has the active COVID. They are going to take care of a child who is clean, and we try to keep them clean. So a lot of times, you know, that may take the stress out of the caregiver, who may be willing to come and help, but is afraid for themselves. Your children are the safe, quote unquote, patients these days.
So some of the things that have been asked are related to making the decision to go to the ER when you see these red flags that Dr. Wirrell spoke about, and especially if they're having respiratory issues or if they are in status, what can the families expect as far as will the staff there be ready for a patient with a DEE and the variability from one DEE to the other. How can they prep the staff that's taking, and the overwhelmed staff that's taking patients at this time? And what guidance would you give families for advocating for their children? And the risk benefit of making that decision when they see the red flags.
Let me say, I think you guys as families, you know your children best, and I think don't second guess yourself. If you see a big change in your child, you see your child getting increasingly short of breath, looking cyanotic, you see a child who is having status or having a seizure emergency, do not second guess yourself. That is a medical emergency, and the emergency rooms are still open, and they are open for exactly those type of cases. So you should definitely not hesitate to seek care. I think it's going to be obviously very busy in the emergency departments, more than likely. And so there is a triage process in emergency departments. And so they will certainly take the sickest of the sick in first. And so if you arrive and your child is in status epilepticus or your child is in severe respiratory distress, your child will be moved to the front of the line and they will address that. If it is a less urgent issue, then that is something that you will likely have to wait a bit for. So they really are going to be in doing a lot of triage. And so the wait may be a bit longer, but if it's urgent, emergent, they will get your child will be looked after. I guess the other thing to say just with the seizure standpoint is many families have copies of seizure rescue plans and seizure action plans. If you give your medication, it hasn't worked, then what is your neurologist recommending? And that's really, really helpful as well. Many families will actually house that at their local emergency department so they can actually call and say, look, my child is coming in, and they pull that rescue plan, and it's very, very helpful to the emergency room people because they know exactly what to do. They know what medications to give, what medications your child has not responded to.
Just speaking.
I agree. Okay, go ahead.
No, go ahead.
What I wanted to say, I totally agree with these recommendations because the COVID is a respiratory, primarily illness. If you have a child who never had or very infrequently had actually respiratory problems, and now they are gasping for air and you have nothing to offer at home, clearly you have no choice. If on the other hand, your child is somebody who needs a lot of respiratory care chronically, and you have oxygen at home and you have the pulse oximeter to monitor the progression of the disease, and you feel comfortable doing so, you can talk with your doctor on the phone and we can say, okay, double the amount of oxygen, give an extra treatment of that, to do the physical therapy, the chest physical therapy, and see if there is any response. And if there is a response, you can avoid the trip to the emergency room. If you have done all of these things or you feel that it is beyond your ability, then I totally agree. You go to the emergency room, no questions asked. And as Dr. Wirrell said, if your child is indeed in a very urgent situation, they are going to be moved, immediately to the very acute care because, they are the sickest patients.
So the only thing that I would add is speaking from the other side, from a health system perspective, and how we triage and how we deal with people coming in. I think that if your physician can give the emergency room a heads up and distinguish you from the 500 people who may be showing up with respiratory illnesses that are being triaged in the tent in front of the emergency room, as is happening in many hospitals, because this is a different circumstance. And I think that use your physician as your advocate to sort of help that when you do have to present to the emergency room, that on their end they treat you appropriately in terms of the type of care you need, and bypass a lot of the things that are just being set up to manage the large numbers of people with flu-like illnesses that they're trying to sort through.
So I'm gonna throw a bunch of questions at you guys to piggyback on that discussion. We have a group of really savvy caregivers, some of which have oxygen at home and have the resources to care for their child's respiratory issues. And we have questions about previous exposure to coronavirus strain. We have questions about previous pneumonias. We have questions about immunosuppressant therapies. We have the gamut of individualized patients that would increase their susceptibilities. Could you speak to any of those? And Dr. Fraimow, just what you said, that your child is different, and giving them a heads up of just how your child is different. But from the caregiver's point of view, this is their daily life. They do this all the time. They know their child, but some of them are even asking, how do we know if we're being a little bit overconfident about what we do day in and day out, because we've never dealt with this particular issue. And though we have O2 at home and pulse oximeters and breathing treatment, can we sometimes overjudge our ability? And what are red flags that we should be aware of when we need to seek more care sooner rather than later?
Well, if I can start with this, because it is the respiratory. In general, the criteria are always the same for respiratory insufficiency or failure. If your child becomes dusky, if he or she are breathing much faster or much slower than the usual, if they have visible signs of cyanosis, this is obviously a critical situation. For situations that are not very clear-cut, if you have indeed the oxygen and you have the oximeter, and you increase the amount of oxygen you are giving, and the oximeter does not go any higher or even drops even a little lower, that means that this lung is under an extreme distress and is possibly and probably failing. And that should be a red flag, that you increase the treatment and you don't get any response. If it is a mild case, by giving a little oxygen, the child goes back to the normal and you say, okay, I have a little more time, to try. But if you don't see any response, then, this is the time that you say, I need to go to the hospital. One issue of caution is that a lot of patients with neurologic disorders have either from the beginning or develop sooner or later various degrees of muscle weakness. And that means that they do not show their respiratory distress the same way with an otherwise healthy person. They do not have the retractions in the chest wall. You don't see the ribs, popping out with every breath. And that does not mean that they are doing well. They just cannot show their distress the way that other people do. So for this one, you have to see the ability of the child to respond to you, to see how active they are, within the confines. And as my colleague said, you know your children better than anybody else. If your child looks different to you, different in a bad way, I always take that as one of the most critical signs.
I'm going to take that as the
yeah,
best
I'm done. Yeah.
Okay. Would you give any advice? That one of the questions was, can they increase the health of the respiratory system in any way during these times for their child?
The answer is yes, but I would be in consultation with the physician who manages normally the respiratory care. Yes, I would say give more of that, or if the child is getting some support only a few hours a day, I would say, okay, keep them longer or keep them for the entire day. There are a lot of things that can be done at home. However, you should have close monitoring with your doctor, report the symptoms, report the responses you get from the escalation of therapy, so you don't run the risk of reaching the absolute and then it's too late to do anything more.
Does anyone want to speak towards the new guidance regarding Motrin versus acetaminophen?
Sure, I will be happy to address that. So there was essentially a study from France that suggested there might be a potential adverse effects from using ibuprofen that was widely picked up in the media. There has been a lot of walk back of that claim, and most people who have sort of objectively looked at this don't believe that the data is really there to say that ibuprofen is harmful in the course of COVID disease. I mean, obviously, we're learning a lot as we go, and the news changes day to day in terms of what is effective and what isn't. For patients who are able to take ibuprofen and don't have any liver issues with that, acetaminophen, and don't have any liver issues with that, acetaminophen is perfectly fine, but we don't believe, at least as of right now, that there is harm from ibuprofen, but this is obviously an evolving story. I don't know if anyone has other thoughts.
Yes, no, I agree with you. The data are based on associations, and it was primarily people who actually died, and they found that more of those who died had taken during the course of the illness ibuprofen, which is a pretty widely standard use medication, and they started talking about could the medication elicit, some weird reaction from the person. If acetaminophen can help your child if they had high fever, that's fine until we clarify the situation. On the other hand, if acetaminophen does not do anything for your child, then again, you have to deal with a real problem and a theoretical problem. And my advice usually is I try to treat the real problem that is in front of me, and hopefully, there is not going to be this severe reaction. but it is not a fact that you get worse with ibuprofen, to my knowledge. And these are all, I should say, these are all adult data. Yes, a lot of people, had taken ibuprofen. However, they were also 90 years old with heart failure. So to isolate the ibuprofen as the main reason that they did badly, I think it's not something that I would, follow and change completely and eliminate the medication.
I think that's very helpful, because that the media coverage has been moving around quite a bit and concerning to parents, I think. And I guess a good follow-up is the use of chloroquine to treat children, because that is the more recent one that has hit the media. And are there any known concerns and any, I suppose, in children, or what do you know about the recent trial?
So there has been data for a while suggesting that hydrochloroquine, which is a drug that's primarily used in rheumatologic patients, but was a malaria drug, but may have benefit in treatment of COVID disease. And the more recent data suggests that chloroquine may have benefit as well. A lot of this data is still fairly preliminary. And what's happening is we have a very young disease that we only have 3 months worth of track record for, and we have a lot of trials that are ongoing, that the data is coming out fast and furious and hard to fully vet it. But it does look like there may be benefits to both chloroquine and hydroxychloroquine. Chloroquine, we know, is a malaria drug that has been widely used for treatment of malaria in adults and children for many, many years. So we know about the safety of the drug. Whether the chloroquine needs to be combined with other drugs like antibiotics, such as azithromycin, or whether it works on its own, a lot of those details still need to be sorted out. So the data looks encouraging, but I don't think that we have prime time recommendations that this will definitely be of benefit in everyone with COVID disease.
Okay, I like honest and cautious answer. So I have a couple systems questions and a specific neurodevelopmental disorder question regarding respiratory treatments. So that several of the caregivers use ABA, and they had questions regarding neurodevelopmental disorder patients that are unable to respond when you ask them to clear their chest, cough up something. What are your recommendations for the patients in our population, Dr. Koumbourliss, regarding these sorts of issues?
Well, there are two different categories of patients. There are patients who have the ability to cough, but either because of their age or because of the developmental state, cannot do it on command. And these people would respond to some extent to intense chest physical therapy that will mobilize mucus, bring it up, as close to the throat as possible, and then, you trigger the cough reflex, and hopefully, they are going to cough it out. Then there are patients who have the muscle weakness that no matter how much they want to do it, they would like to do it, they cannot. And these patients hopefully have already the cough assist device that essentially reproduces mechanically in the reverse way what we normally do with the cough and helps them clear up their chest. And clearly, if they got sick, they need to get the treatment as often as it is necessary. Normally, we say do it a couple of times a day, first thing in the morning and before bedtime. During an acute illness, you do it essentially as frequently as it is necessary.
And for Dr. I'm sorry, does anyone else have anything to add to that who's worked with this population?
Yep.
The system questions that I think everyone has a concern with is the triaging and how this may impact children's hospitals. One of the caregivers that was on the call shared that she worked with in the healthcare administration for a large health system, and that she wanted people to be aware that hospitals are restricting visitors and people accompanying an ill person. That for her system, children are limited to one person. Their visitor restrictions are on the website, so that you should check that in advance to going in. People were interested, though, that if ventilators are being impacted, many of those numbers are being discussed relative to adults and not children. So the question of how those will impact the children's hospital, and if there was any thoughts on that.
Well, I believe there will be a lot of variability from hospital to hospital and from city to city, depending on how overwhelmed they are. In our hospital, for example, the policy is that patients who need to be hospitalized for whatever reason, they can have only 2 visitors. They have to be above 18 years of age. And we would request to have the same visitors throughout the hospitalization. If it is, let's say, the mother and the father or the grandparent or whatever, that they are the only ones, so we don't have 15 different family members coming into the hospital. And the second thing is that everybody who enters the hospital these days is being screened in the entrance, on whether they have symptoms themselves, and if there is any suspicion that they may be ill, they are not going to be allowed to enter the hospital.
Yeah, I think that is becoming pretty much universal in hospitals throughout the United States in an effort to both protect the individuals in the hospital and protect the patients who are coming in from other patients. We are in our hospital, they're actually taking temperatures of everybody who's coming in when they enter through, for ambulatory visits or through the hospital setting. So there's a lot of things that are being done in hospital systems to try and decrease the number of folks coming in to the hospital to protect everyone else that's there. Those in our hospital, these limits of visitors or support personnel are a little bit flexible on a case-by-case basis. And I know in other hospitals they are too. We sort of establish this is what our threshold is, but then for an individual case where someone might need more than a single support person, that those things can be adjusted as need be.
And that's the same situation in our hospital.
for that caregiver who works in the hospital system, if they have confirmed cases in their hospital, is it safe for them to work at the bedside of a child with one of these DEEs?
So sorry, you're saying if somebody works in a hospital and there is a case of COVID in their hospital?
They have, one of the individual questions that came in was they have a confirmed case of COVID in the hospital where they work, and they are concerned it's not safe for them to be the primary caregiver for their child that's susceptible.
So I think it really depends on how close that person has been in contact, but I'm going to let Henry, you're the ID expert. I'm going to let you answer that.
Right. So I think that there is a lot happening in the United States right now. You all watch, I'm sure, the media with the number of cases in the United States climbing upward. A lot of that is not necessarily because there are all of a sudden these new cases. We're testing more and more, we're finding more, and we're recognizing that there has been transmission in many communities already for a period of time. We are dealing with the fact that more and more of us are used to be 2 degrees of separation from a confirmed COVID case. Now many of us are no more than 1 degree of separation from a confirmed COVID case. Most hospitals, if they don't have COVID cases by now, is that they're failing to recognize them. And I think that that is true. And many of our healthcare workers are at as much or more risk of exposure to virus from people, from their friends in the community, as they are from the patients that they know have it, that we're using appropriate protections in the hospital. So I think that having cases in the hospital should not disqualify somebody from being a caregiver. I think that it's just a marker that there is COVID in your community. I don't know if anyone has anything to add.
No, I totally agree. In the hospitals, at least we know who has it, and we try to protect ourselves.
Mm-hmm.
We are going over. Gabby had asked if how we're doing on time in regards to the panelists and everything you have today for your hospital work.
Yeah.
We have a few more questions that we can address, but we've covered a lot of topics that are overlapping. Do you have anything to add? I know one thing that was asked was for our European partners, they get a lot of their drugs from specialty pharmacies, especially Epidiolex, and they were wondering whether they should be looking into alternatives.
So we have heard that there is no concerns. We've heard that actually from the company, and the FDA has not identified any concerns with production for Epidiolex. So I think right now that's not something that I would be worried about. I think the likelihood is that we are going to continue to get Epidiolex. They are still allowing shipments, so I don't see that as a concern.
We have a number of people on the chat expressing their gratitude for you making time today, given how tired and overwhelmed with the extra work you have had. So thank you very much for spending time with us today.
Yes, thank you. Thank you to our panelists. We know you are incredibly busy. We know that you are in very high demand right now. So we're so grateful that you were able to give some of your time to help our DEE families get some of their questions answered. As Heidi said, we covered a lot of ground. I know there are still additional questions out there. We're looking at trying to have a follow-up session and do some more sessions around COVID-19. So please make sure that you follow us and like us so that you get updates about any other things that are coming through. This session has been recorded and will be online within 24 hours at our the deepconnections.net website, along with the slides for your downloading and review. And I'll post all of those links on Facebook and Twitter. So please share widely, watch again to try to take in all these nuggets of wisdom from our experts. And we thank you families for taking time as well to be with us. We know life is so busy and these are really uncertain times. So thank you for being with us, and we'll continue to try to bring more resources to you. If you have thoughts about future webinars, please let us know, and we'll do our best to try to get those out to you as quickly as we can. So thank you again to everybody, and stay safe out there.
Debbie, will you share the name of the Facebook page and also where the recording will be available for our international friends?
Sure. So deepconnections.net is where the webinar and slides will be hosted. And if you want to follow us on Facebook, we are at Deep Connections Epilepsy. And on Twitter, we are Deep Connection, DEE_P Connection. And I'll be sending out an email to all the participants with the links, both to all of the relevant pages. All right, anything else?
Okay.
I think we're good. Thank you so much, Dr. Koumbourliss.
Good night, everybody.
Dr. Fraimow.
Good night.
Thank
Stay
you.
well.
Thanks to Heidi for
Good night.
Thank you.
moderation.
Thank you.
Take care, all of you.
everyone.
Bye.
Bye-bye.
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 Bye-bye.